Hey, good morning, Dr. A.
Good morning, Dr. Saylor.
Hector, how are you doing?
Top of the morning, sir.
Hey, Casey.
Good morning.
So, what are we going to talk about today?
Today we're going to talk about something that our patients might be noticing about their own teeth. It's when the edges of your front teeth start getting blue.
Yes. You know, we try to bring up subjects that we see a lot just out in the wild or something that we see in our patients. And this is one that I could give you a little story on. My sister-in-law, you know, she lives over on the other coast. We see them twice a year or something like this. And I've been noticing on her, you know, pretty lady, she's getting close to 50, and really always a nice smile, but I've seen this line, it almost looks like halfway across her teeth, where it gets blue. And I had been waiting for her to bring it up to me, and she hasn't up until last year. She goes, Larry, why are my teeth turning blue? I'm like, I'm glad you asked. And if I were to sit her down in the chair and look from like the top to where you see what's happening on the edges of her teeth, pretty sure, because I haven't done this yet, but pretty sure that what is happening is she's wearing the enamel thin. So since we're talking about her diagnosis, we'd like to talk about different reasons for why you would wear the enamel thin. So just picture this. You have the tooth, and we'll put up a better diagram than my hand, but you have the top tooth, you have the bottom tooth, and as they collide, most people think they fit together like this. They don't. They fit together like this, Casey, right? You know that. Top and then the bottom. And as you're chewing, if there's collisions, if the friction is too much, it gets thin. And where that enamel gets thin, it gets
Translucent.
and translucent can look dark, it can look blue, it can look gray. And therefore you get that two-tone that I'm sure a lot of people can relate to this, which is why we're doing this video. So let's talk about the reasons.
Yeah, there's a couple causes or reasons that this happens over time.
We'll share, like, you go first.
Yeah. So the first one is something we call a parafunctional habit. And those are things that you're doing with your teeth that you're not supposed to. Chewing your nails, chewing on ice, biting your cuticles. Yeah, all these things, opening things with your teeth, those are putting extra friction and extra stress on your teeth, and you're physically putting your teeth in a position that they're not supposed to be. So that is wearing through your enamel faster by doing those bad habits.
Yeah, and in those cases of parafunction, you typically see uneven wear across the edge. And in those cases, maybe not so much the blue that I'm talking about for my sister-in-law, but you could see that the edges start to look uneven and kind of ragged looking.
Yeah.
So parafunction is a good household word that our viewers should know. And I think another one that comes up is when we talk about the shoebox all the time, where you have the lid on the box, and I don't know, I used to keep a bunch of shoe boxes and sometimes I would get them mixed up, and trying to find out which box fit which lid, sometimes, you know, it's a mismatch. And that happens with the jaw, where your bottom jaw is supposed to be the box, and the top jaw, your maxilla, is the top box, is the lid. And so if there's a lot of friction between the top and the bottom, which we see a lot, it happens over time, where it could be right at one point where you have enough what we call overjet, and then over time those teeth just come in like this. And it's natural for them to come in like this because the cheeks and lips are like a big rubber band that pulls everything in, especially if you're kind of tight-lipped, a little bit more intense, a little bit more, hold more stress in your face. It's going to pull those teeth in over time, and then you are making that lid tight. now as you chew or talk or function or clench and grind, you're going to wear those edges thin.
Yeah, we call that a constricted envelope.
Constricted envelope, which is another good term.
Yeah.
Yeah, it's a constricted envelope.
Another one is from erosion, acid.
Good one.
So there's extrinsic from your diet. If you're having a lot of pineapple juice, biting into lemons, or intrinsic, GERD, acid reflux.
Yeah.
So that kind of acid is wearing through the enamel, typically on the tongue side, on the inside. Hence why, as that gets thinner from that acid, it gets more translucent, starts seeing that blue, that line.
Yeah, that's a pretty popular one. So kind of related to that, another thing, that condition that will wear the teeth thin and create problems with the enamel edges would be like airway constrictions, sleep apnea problems. This is another one we see a lot of. And this one's a little more nuanced, a little more complicated. You know, we see patients all the time where they're wearing a CPAP. I mean, it's like all the time, right? And the CPAP has to do with you're having trouble with a constricted airway, where when that airway is constricted, especially at night when you're on your back sleeping and everything falls to the back of your throat, your body, out of just survival, is going to find a way to open that airway. And you know, that is typically going to be by moving your bottom jaw forward so your tongue has room to not close up the back of your throat. And when you're jutting your jaw forward like that, unconsciously, your front teeth are going to get in the way, and you'll see that type of wear pattern. And I think, are those the main things? So we got the restricted airway, sleep apnea issue. We have the erosion. We have the constricted envelope with the shoebox issue, and we have the parafunction. I think that pretty much covers the conditions that we see. So the next natural progression of this conversation would be, how do you know which is which, right? And that is what you're relying on your dental professional to be able to diagnose correctly. Because if you diagnose this the wrong way, you're going to run into problems. At least when I first started, I would treat these conditions, and if I didn't have a diagnosis, the patient would come back and say, your bonding broke. You need to use something stronger. That happens all the time. Not anymore, because we're very careful about making the diagnosis. So you want to talk a little bit about the diagnosis?
Yeah, so it's like if you're going to fix something but you don't treat the cause, we're missing a step. So the diagnosis takes a very thorough clinical exam, asking the right questions and figuring out in what category do you fall. You can fall in more than one of these reasons for why your teeth are getting extra wear. And from actually figuring out the patient's risk, so are they more of a clencher and grinder? Do they have these parafunctional habits? Is airway involved? Comes from analyzing and doing our clinical exam.
Yeah, so let's take airway. What are some signs? You know, you would hope your professional, I always think when I'm dealing with a professional, they could look at me and tell a story, right?
Yeah, and that takes a trained eye. You got to know what you're looking for.
Yes. So what are some of the things that you would look at?
So we're looking at the space for the tongue. So there's different degrees as to how blocked your airway might be. Then there's signs in the face. If you have more dark circles, kind of seeing how tense your muscles are. These little things that we can look at really give us a clue as to, do you have an airway issue?
What about measurements?
Yeah, there's a few measurements. So if you think about it, your tongue is a huge part of airway. So if your tongue doesn't have the right space or room, that could be contributing. So one of the measurements is the width from molar to molar on the upper shoebox, on the maxilla.
Yeah.
And another one is kind of looking at the space vertically as well.
Yeah. So there's some measurements that we can index or use as an index and see where you fall. There's a physical appearance of looking at somebody's face and seeing maybe the dark rings, just a tired look, a fatigued look in the face. And, you know, oftentimes people that are, I talked to a guy yesterday, he was having waking episodes 52 times in an hour and was just fatigued, worn out, falling asleep behind the wheel when driving, you know, at stoplights, falling asleep literally. Ended up having a bypass, and also developed problems with diabetes, all related to his sleep apnea, airway constriction. And believe me, we saw it in the teeth. I'm looking at his teeth like, before I understood, what is going on? What am I missing here? And we put it all together, and he got a sleep study and ended up changing a lot of his habits and working with that airway constriction. The guy, I mean, he broke down yesterday and, you know, crying on how much it changed his life.
Yeah, wearing the CPAP has
Wearing
really
the CPAP and understanding what's going on, and now the next step is putting back his teeth, you know, with the damage that was done from that. So I think we're getting down a rabbit hole. But
yeah, airway is an important topic, absolutely, but that's kind of not our focus today.
Yeah, and we were talking about how to diagnose this. That's how you diagnose airway.
Yeah.
Now, how about erosion?
Yeah, that's where we look at the teeth in that view from the incisal edge. I mean, you're not looking as a patient at your teeth from the inside or the edges, you're looking at it straight on. For us, we see erosion based off what the teeth look like, the enamel. It'll have that shiny surface to it, this kind of crater-like wear to it.
Yeah, the craters. And, you know, a lot of times the patient would come to me for a second opinion saying, my dentist will not treat me because he says I'm grinding my teeth really bad. But I swear I don't grind. My husband doesn't hear me grind. I do not grind my teeth. And I look at it and I go, this is erosion. How do I know? It doesn't match. So if it's grinding or pair function, you can find a lock and key like a puzzle. If it's erosion, you look at the top and it's worn down. You don't have the adjacent wear on the opposing arch. It's simple.
And sometimes you see it from erosion on the posterior teeth too, cratering.
Yeah, you like a loss of vertical. So the back teeth will crater and wear down. You lose the enamel in the back teeth, and then it collapses, and your front teeth hit too hard. Yeah, so those are solid examples of how to diagnose grinding from erosion. And grinding, yes, you match up the facets. You find out how the teeth fit together, and what do patients say when you show them?
Oh my gosh, I do that?
Or I don't do that.
Right.
You're like, it's happening some way.
Right.
And that is how it's happening.
Yeah.
Yeah. And of course it happens when you're not realizing it. So it's either happening at night or it's happening during the day. And I had to find out myself. I mean, I'll be working on a patient and get into a tough situation and find out that I'm putting my teeth together in a pair functional way outside of a normal range of function, which I know are not good for my teeth. Now, right now, I'm wearing my Invisalign, which I love because I don't have to worry about pair function, right? It's covered. So that's how we diagnose it. How do you treat it?
So you have to replace the lost enamel. And there's different ways that we replace it. It could be through a BioClear, bonding, through veneers, or crowns. And so the one that you need really depends on your diagnosis and how much enamel are we trying to replace.
Right. So like in a patient with GERD, if they've destroyed the back side of the tooth from acid coming up and splashing onto the back side of your upper teeth, that's probably going to be a crown. Because the veneer covers the front and side. The back side of that tooth needs to be protected. The good news is if it is GERD and you protect those surfaces with a crown, the acid's not going to bother that. So it protects it from further erosion. But yes, get with your physician, get on the proper medicine so that acid will not be produced. Now, why it's produced is a whole nother story, right?
Yeah.
Gluten allergies, food sensitivities, all of that, airway, those can cause the acid. What else?
So let's say it's the edge-to-edge grinding and the position of the teeth.
function.
Yeah. So if you've lost those edges, rebuilding those edges are important, and for that we can do something like a BioClear. What we love about the BioClears is it's something that if it were to chip, we're talking about somebody who, let's say, bites their nails. First, stopping the habit is important. But building that back up, if for any reason, if that were to chip again, those BioClears can be repaired.
Repaired, right. Yes, and what happens is if you have a nail biter or somebody who bites things with their teeth that they shouldn't, when you repair those edges, what do they say?
Will it last?
Well, typically what they say is, I can't do that anymore. They're like, I can't, and I'm like, good.
Yeah.
They go, I don't like that. I'm like, listen, do you understand? This is costing you thousands of dollars.
Yeah.
And they look at me, they go, okay, I understand, but I want to bite my nails.
Yeah.
I'm like, too bad.
Years of biting your nails, your teeth become lock and key.
Yeah,
and so as
they
we
fit
rebuild
perfectly.
Yeah,
and you become a
same.
nail biting machine.
Gotcha, yeah.
You fix that, and the first thing they tell me is, I don't like the way my teeth fit together. I'm like, well, you haven't had them like that in a long, long time.
Because they're trying to do that bad habit again.
Yeah.
Yeah.
And then the other one with the constricted envelope, if you, and I used to do this, is they would be really tight. So, Dr. A, what do you do if they're really tight and you want to do crowns?
You'd have to prep a lot.
Yeah.
Kind of make the room.
And it would be tough as a younger dentist, and she's so lucky she doesn't have to go through any of these things because I teach her about what not to do, right?
He's right. He's right.
But
yeah.
what I used to have to do is I would be preparing it, and I'm like, I don't have any room for my crown. And then to get room, you have to take more away, and then you end up with a really thin little tooth. And then what do you have to do? You still have to go down to the bottom and grind on those. It's not a good situation. What has changed that?
The ability to actually move the teeth
Yeah.
out of that constricted envelope.
Invisalign. And we use this combination all the time. We say, you know, there's a little friction between your front teeth. We need to reduce that friction, get back the overjet. Now we can do conservative preparations.
Exactly. And when we plan it, it's like we're thinking with the end in mind. If we can plan for where we want the teeth to be, it makes the restorations so much more straightforward, more predictable. It helps a lot.
Yeah, and patients like the way it looks too when you put the teeth back in the right spot because their face has more support, their lips have more support. Women, I know you like thicker lips, right? So when your teeth are coming in, your lips roll under like a little chicken lip type of situation. So when you put the teeth back out there, your lip rolls and it looks fuller. All bonuses, and I always say form follows function. So when you put it back into the right function, the form looks better.
Absolutely.
Did we miss one as
No,
far as treatment? Yeah,
we
so
talked
that's
about all
good.
4.
You know, we use, and you know, if it's an airway situation, yes, you have to fix that airway issue. And a lot of times that means expanding the arches, which is Invisalign again, or regular orthodontics, depending on how much expansion needs to be done. And once you expand like that, now you have the room for your tongue, and it looks better again. Because if it gets sunken in, you can kind of see that in the face a lot of times. I mean, we used to see this a lot with extraction orthodontics.
Yeah. They take out a premolar or 4
4 premolars, and then everything would be kind of sunken in. So that is the treatment. I guess what would be appropriate as well would be to talk about bite guards.
Yep.
Bite guards is another thing that in the beginning, when I used to use bite guards, I thought it was a cure-all. In my head, we do a beautiful restorative case, and it's like, we're gonna put you in a bite guard, and it's gonna protect this. And in my head, this patient would be wearing this bite guard around the clock, and you know, my restorations would be protected. That, in my mind, I was treating it, but a bite guard is not a cure-all. You wanna talk a little bit about bite guards?
Yeah. So typically a patient will be wearing their bite guard at night. So it feels great when we say, a bite guard, because it is a really helpful tool to protect the teeth. Because let's say you have any clenching or grinding, you are putting any of that stress that you do onto the plastic, onto the bite guard. But patients aren't wearing it all day. They're wearing it at night.
Mm-hmm.
But it's still a wonderful tool if you wear it at night. And the key for us when diagnosing a bite guard is having our patients bring it back at their hygiene visits.
Mm-hmm.
So we can really look at that bite guard, that surface, and figure out what they're doing.
Yes. So when we look at this in the hygiene visit, first of all, if they go, oh, I didn't bring it, then it's out of sight, out of mind. I'm like, well, are you wearing it? And there are, I wish I had the number on this, but if I were to guess, I would estimate that out of the bite guards that we diagnose, and we say that we're diagnosed because we're only going to recommend it if we diagnose it, I would say a good 30% do not wear the bite guard for whatever reason. Mm-hmm. It can be they just can't get in a habit of it, or they don't like the way it feels, and we can go into that a little bit. It's worthwhile. But let's just say that the 70% approximately that are wearing a bite guard, now what are you looking for in the hygiene visit?
We're looking at the surface if they are putting dents or divots into the plastic. So someone comes in and that bite guard is flat, there's no dents or divots. They're not really grinding on that bite guard at night, and that could be a sign of, well, maybe they don't really need one.
Yeah.
But then we have those patients that come in and either they have these straight dents into it. Like for me, that's what my bite guard looks like. I clench into it.
Mm-hmm.
Or we have those that you can see the streaks through the plastic and where they're really grinding and they move their jaw a lot.
They're troughing it. They get deep troughs in their bite guard, and in fact, the worst ones get deep troughs on both sides. It looks like a typewriter going back and forth, and we have to take that and get rid of those troughs and smooth it again. And they go through bite guards about once every 3 years because they grind through it. But I show them that bite guard and I go, you know what this represents? And they go, that I grind a lot? And I go, thousands of dollars that you're saving by wearing it. And they already know it because they can't go without it. Because, I mean, what do they say if they say they forget to wear it?
That they don't like the feeling of not having it.
Yeah, they feel like their face is tired. Like they wake up in the morning and go, oh my God, I could tell I didn't wear my bite guard because my whole face is just so worn out. And it's like they've been exercising all night long. But when you exercise against your teeth, you're pushing against resistance. When you exercise and grind against the bite guard, the friction is reduced so much that it doesn't wear the muscles out. And it also protects the joint.
Yeah.
So very, really, really important. And the other last thing we'll say, we'll wrap this up, about the bite guards would be if somebody can't wear the bite guard and they need a bite guard, what do we have to do?
And to find an alternative.
Yeah, we have to find the type of bite guard that they can wear. We go through this quite a bit because I'm pretty committed to making sure that we exhaust all the options out there. So I'm a prime example. I was one of the 30% that couldn't wear the bite guard. I hate to admit that. I'd still diagnose it and push people to wear it because I know my patients that wore it, like the case I was describing, that it saves their teeth. So in my head, I have to separate myself from the sample group because the majority, good 70%, can wear it. And I was one that, like you, clench on the bite guard, but I didn't like the feeling because I'm a better sleeper now, but I wasn't a great sleeper anyway. So I'd sit there and just kind of fidget with it. And I'm like, God, take this thing out. For whatever reason, and this was really by accident, when I got into Invisalign, I like the way it feels in my mouth. I want these in all the time. Now I'm in full-time retention right now, so I have them in all the time. And I have to get myself ready for when I have to get these out.
Yeah.
Because I just like having them in. And so, yes, I love the idea that I'll be wearing these every single night because I'll tell you, in bad grinders and clinchers will tell you sometimes they wake themselves up clinching and grinding, or sometimes they can even find tooth dust that they've created, like sawdust, which is bad. I mean, it's a bad habit. So, yes, this type of bite guard, I think anybody could wear if they can't wear the regular type of bite guard. But the comments we get a lot from people is the bite guard's too big, or the bite guard's too stiff. Can I have a soft bite guard? What do you say about that?
Now, a
Why?
a soft bite guard, it's like you're trying to work out your muscles. It's something that will be in between, and you don't want your muscles to get stronger and be worked out at night
Right.
with that soft bite guard in the middle.
Yeah.
Yeah.
So that, like the over-counter bite guards, it's like, this guy wants $800 something for a bite guard. I'm just going to go to CVS and pick up one of these over the counter or order one online. Guys, we've talked about this before. You don't want to do that because it will be an orthodontic device. And they come in, I'm like, what in the world is happening with your bite? And they go, what do you mean? Oh, your teeth don't fit together. They're like, could it have something to do with this? And they pull out this little toy, a bite guard that they've ordered online. I'm like, oh my God, where'd you get that?
Right.
And they go, I ordered it on biteguard.com.
Yeah.
I'm like, okay. It's a mess, guys. So yes, you don't want a spongy type of bite guard that you can fit there and do exercises all day long. Now, I think there is a population out there that wants bigger masseters, right? Casey, is this what the younger kids are doing?
Don't ask me, kind of.
I think so. I mean, oh right, you're the youngest one. Yes, I've seen this before where they go, they want to exercise their jaw, so they have a broader jawline.
I have seen stuff like
Yeah,
that.
crazy. Guys, don't exercise your masseters. I mean, they're destructive if they're too thick. So we've covered a lot of stuff. Very valuable stuff that's going to hopefully relate to people out there that are having this issue. And again, we always try to be the resource for our patients to keep their teeth for life, and this can certainly help.